After years and years of training to other colleagues, I think I have learned the training process and the learning process of many surgical steps, and among them vitrectomy, of course. I have tried to reconstruct them through the common errors that we all make at the beginning and to offer suggestions to speed up the process and the path to reach the fluent surgical step. I think, first of all, we have to comment some philosophical approach to our surgery, especially vitrectomy, and then concentrate on the techniques, so how to make a surgical step, and then the strategies will come. Strategy means planning your surgical step since the beginning based on the preoperative knowledge and informations on the eye and the patients. But that is the last thing to do. First of all, we have to start with some basic concepts. And in this way, you will learn not just how to do it, but how to do it right. So, with philosophy, I mean concentrating on the correct approach to our surgery. There are two fundamental rules to memorize, the MEHF and ZFF. Let's see one by one. MEHF is dedicated to coordination. I think surgery is like dancing. We make like a micro dance because we make micro movement inside the eye. And we need to learn first how to coordinate mind, eyes, heart, and feet. They have to work together. You know that most of the time, constantly, especially when we are inside the eye, we need to make a different movement with each hand and different movement with our feet. One foot is dedicated to the foot pedal of the microscope, and the other foot is dedicated to the instruments. And they make different moves. And we move in the eye like we are moving inside water. It's like dancing inside water or inside air most of the time. And so our movement have consequences. What we do in one spot can create a consequence in another. So our eye needs to check everywhere. We need to have a distributive attention or attention distributed to different spots inside the eye. And we need to know how much to do, when to stop, and when to change maneuvers. So mind, eyes, heart, and feet have to work together in a micro dance. The second rule is dedicated to remember that only being able to see is being able to do. So, to be able to make any movement, first of all, we have to be able to see where we are and what we are doing. So, zoom, field, focus. Before entering the eye with any instrument, you have to find your way, find your place in the eye. So, this is the sequence of steps. You enter the eye, you need the light, and then you just first zoom, create the right magnification, the width of field, and the focus. And the focus can be in different parts of the eye. If you need to work inside the vitreous chamber, you focus on the instrument, and if you need to work on the retina, you focus on the retina. When you have memorized these rules, then you can start. You can start with each step, and we can speak in details about each steps, like creating a sclerotomy. Sclerotomy is the door to enter the eye, and there are many types of approaches. Now we all use trocars and cannulas, so small knives to insert in the eye, some tubes that allows an easier in and out with instruments. There are many types of trocars from different companies, but the basic movements are the same and are aimed to build a sclerotomy that should be functional to the following steps. If the sclerotomy is also self-sealing is even better. It means we won't need any suture at the end of surgery. But most of all, the sclerotomy has to be in the right place and made in the right direction, which has to be useful to the instruments. To make a good sclerotomy, since we have to enter the eye with a perforating instrument that has to follow a certain direction, and since the eye is mobile, we need first to stabilize the eye while the trocar enters. And one way is to place a plug 180 degree opposite to the entrance, or we can use forceps. Still, I recommend to place the stabilizing instrument opposite to the entrance. Or we can decide that one hand will stabilize the other, entering not with one instrument but with two instruments simultaneously helps in stabilization. So we can use this matador technique and enter the eye simultaneously with the two trocars. In this way, one hand stabilizes the other. You can just measure the distance from the limbus prior to this maneuver, and with experience, after a while, you don't even need to measure, but it's always wise to follow the rules. A good advice is never enter the eye while the eye is hypotonic, because you risk with your trocar to touch the retina or the crystalline lens in the opposite direction. So you might deal with an eye that is without the vitreous. It could be a second surgery, and so the vitreous the water exit very quickly at the beginning of surgery, and in this case it is hypotonic and you should not proceed. So one way is to use the screwdriver technique, twisting the trocar very quickly and mildly pushing while the trocar enters. If you cannot do that, do not proceed and just inject water or air or viscoelastic in a well visible position, either through a sclerotomy that has been already made, or through the anterior chamber if it is the very first sclerotomy that you cannot make. Also, extremely important to measure exactly the distance from the limbus. I'm showing you an extreme case of an eye with a coloboma of the optic nerve, not only but with an anomaly at the level of the limbus, because the cornea has been covered with conjunctiva naturally. So the limbus is not visible, and only in transillumination, entering with one light, you can complete the sclerotomy on the side with the anomalous limbus. You see with a normal light that the limbus is not visible, while in transillumination you can easily see. It is important to check the infusion line even when we use trocars. The infusion line needs to be well placed into the vitreous chamber. How to check? A common error is to push the infusion right where it is, usually in the lower temporal quadrant where there is not enough space. You need to turn the eye, bring in the infusion line in the temporal fissure and extra rotate, and then push and look. Then, when you know that the cannula of the infusion is in the vitreous chamber, is the time to start infusion. So what is a sclerotomy? Remember that the sclerotomy is not just a hole through which the instrument enters the eye, but it is a fulcrum, and your instruments are the levers. Use them also to stabilize the eye and not just to enter with instruments. Then when you know that this is the right way to look at the sclerotomy, you can do every maneuver. So entering the eye for the first time is scary because the eye is dark and full of terror. This is one colleague approaching the eye for the first time. You see shaking, slow movement, an incorrect approach with the light. The first time we shake, we go slow, we don't find a way, we stay stiff with both hands that are tired after a few minutes, and we don't distribute the light evenly, and of course never follow the rules that I explain. Remember, this was the right way to enter, and concentrating first on zoom, field, focus, and then entering with an instrument. Please never enter with an instrument before completing the zoom, field, focus rule. And then we can approach the vitreous. Remember that detaching the vitreous from the optic nerve is like harvesting a flower with your fingers at the very base. We have to complete a symmetrical induction of posterior vitreous detachment, meaning that we have to approach the optic nerve and then lift the vitrectomy probe toward the crystalline lens. In such a way, we detach the vitreous evenly in each quadrant. We have to make the movement like an L with the short hand of the L along the retina and the long arm of the L from the optic nerve to the crystalline lens. This is the maneuver highlighted by triamcinolone that is staining the vitreous, and we can see the maneuver through the intraoperative OCT view. Anyhow, with our vitrectomy probe, we have to approach the vitreous with this movement, short arm of the L along the retina toward the optic nerve, and then grasping the vitreous and lifting the vitreous anteriorly in front of the optic nerve until we completely detach the vitreous from the retina. We have to be even in all the quadrants and distribute this traction on the vitreous in each quadrant with a similar traction power. This is very helpful to avoid holes and lesions in one of the quadrants in the periphery. This is an example of an asymmetrical vitreous detachment. You see I'm approaching the vitreous toward the optic nerve, but then when I pull toward the nasal side, and this might lead you to making lesions in the temporal sides. And then you can approach the macula. First of all, we stain nowadays. We didn't used to do it, but now we stain the macula to see what we are doing. Remember that you should not inject the staining. You should pour the staining like pouring wine in a glass. And this will help avoid the subretinal injection of staining. And then we can start peeling, finally. There are many ways described to teach peeling, and in the end, I think that once you created the condition to see, the best thing to tell you is look at the membrane, grab it, and peel it. Sometimes you find a cleavage plane, sometimes you have to create it, and some tips are to work at high magnification with a tangential light and not um, a chandelier. You make a zigzag movement pre-retinally away from the fovea, and then you grab, pull, and watch. Always watch what you're pulling. Is it just a membrane or a retina? And then we approach the peripheral vitreous, and remember to look at it like peeling an apple, because in this way you don't leave a vitreous behind. From the posterior to the anterior, you move your vitrectomy probe like you're peeling an apple, meridian by meridian, so you don't leave vitreous back. I can tell you much more about techniques, and my advice is to spend more time learning how to see, indent the eye, move the eye in the correct way, move the light in the correct way, move hand and feet together rather than doing maneuvers. They will just come spontaneously, because to being able to see is to be able to do. And I will encourage you to check the app that I prepare. It's called Vitreoretinal Surgery. And please send me comments to my email on the single chapters.